Hi, I'm Caroline Evendon and welcome to 10 Minute Medicine. So today I'm going to talk about how you clock a neck of femur fracture. So this is a very common thing to be asked to do on a TNO job. So this is the case, you've been bleed to ED to clock a 8 to 4-year-old woman who's fallen at home and her leg is externally rotated. So first, we're taking the history. With a patient who has had a fall, you treat it as obviously this is trauma. So you treat it like a trauma. So you would start with a primary survey. You want to look if there's any other major injuries that need to be dealt with straight away. For example, do they have a head injury? Do they need to go through a CT? Have they got a spinal injury? Does their C spine need stabilizing? And once you've done your primary survey, which most likely, if they've come in as a big fall, will have been done, they've been a trauma call and will have been done in ED anyway. You get the history of what happened. So, why did they fall? How did they fall? Is it because they didn't use their walker and they tripped over some carpet? Or was it actually because they stood up really quickly and their blood pressure dropped? Or were they having chest pain? Was it a cardiac cause of them falling? Because obviously they've fallen and potentially broken their hip that you need to fix. But sometimes we need to find out what the cause of their actual fall was. And were there any precipitating factors of them having a fall? For example, as like I said, a cardiac cause, a neurological cause. Um, and if it sounds like a kind of fall that shouldn't have caused something like a hip fracture, then you might think of a pathological fracture, particularly in someone who's a bit younger, who shouldn't have osteoporosis. Why have they been able to break their hip? Is there, for example, an underlying thing affecting their bone, like a malignancy? Obviously, it's very important to get that past medical history because if they have broken their hip, they're going to be going to theatre. So you need to know if there's anything wrong with their heart. You need to know if there's anything wrong with their lungs. You need to know they have diabetes because they have different pre-op and post-op management. And do they have any cancer that's caused their bones? And a big key thing, because obviously lots of people who've come in with a broken hip are very elderly. Do they have a DNA CPR in place? Do they need to have a DNA CPR in place? Did they need a respect form? An important thing to clock with any patient anyway, doing their respect form, but it's key with a patient who's had a hip fracture. And their drug history, are they on any anticoagulants that need and any antiplatelets that need Helium? So they're most likely going to go to theatre. So they have Parkinson's meds that need to be on time that they haven't got because they've been waiting in ED for 6 hours. And are they on any long-term steroids? So do they need any IV hydrocortisone in theatre? And also, a very important thing is a social history. What is their baseline? To determine what kind of surgery they will have on their hip, you need to know their baseline cognition and fitness. Are they normally bedbound anyway? Did they fall out of bed with carers? Did they live alone? Who's at home? Are they in a residential place? Are they in a care home? So, on examination, as I've said in a previous video, anyone who's unwell, you want to do an A to E. You want to look from top to bottom, make sure you're checking the airway and the breathing and the heart before you're checking the leg. And then you're going to examine the leg. You're going to look at it. Are there any visible deformities, bruising, rashes? You're going to have a feel of it. Do they have any certain tenderness anywhere? And you're going to move it. Can you passively move it? Can they move it at all? If someone's got a fractured hip, you would expect their leg to be short and externally rotated. You also want to check their neurovascular status. Do they have sensation in the lower leg? Can they move their leg? Do they have pulses? Because if they don't, then that's a much bigger emergency and you need to involve other departments, for example, vascular. Do they have tenderness over their GT? That would make you think that they do have a hip fracture. In their groin, when you roll their leg, do they have pain on rolling of their leg? And that also makes you think that there's a hip fracture. And can they weight bear? Sometimes you do have patients who are very delirious, who have dementia, that are able to somehow walk around on their broken hip, but most likely they're not going to be able to walk around. You also want to have a look at the other limbs. Have they also broken their arm? Have they broken their wrist? It's very common when someone comes in with a broken hip for people to miss the other injuries that they got from their fall. And you want to, at this point, you've examined the leg, you've decided which leg where the pain is. At this point, it's a good idea to mark the affected leg. We get a permanent marker. There's them on the wall that they're in ED with an arrow. So when they go to theatre that evening, tomorrow morning, that they know they're operating on the right leg. A real key thing to do is an AMT, because an AMT will determine what surgery they're going to have and if they're going to theatre at all. So these are the questions in the AMT. I probably don't need to go through them. And it just gets what someone's cognition is like there and then. Are they currently delirious? Do they know where they are? And it also means we've got a baseline for when after surgery, are they improving? Are they now becoming delirious because they've now got a pneumonia, because they're now constipated, because they're now in retention? And to calculate a clinical frailty score. So most patients who come in to hospital, particularly in medicine clerking, someone will calculate their clinical frailty score. But it's a good thing to know, because again, it's going to impact, the consultant is going to ask you what's their frailty score, because that's going to impact what surgery they're going to do. And so a lot of patients we see are moderately frail and severely frail. And these are investigations you're going to order. Obviously, you're going to order an x-ray of the pelvis, but if the x-ray doesn't show a fracture and you still think there is a fracture, you should get a CT, because a CT is much more likely to pick up a fracture. You're going to get a chest x-ray. These people might have been on the floor for a while. They might have a pneumonia. They're going to theatre. You need to know what's going on with their lungs, and get a baseline ECG as well. You need to know if they've got a heart block. If they've also just had an MI when they're falling, it also means they have a baseline for when something else happens. And then the bloods, you want to get a full blood count. You want to know their hemoglobin, they haven't got an infection. You want to know their baseline kidney function. And you need to do a group and save, because they're going to be going to theatre. And it's important to know that if they've never had a group and save done before, that you're going to need to do two. But if they've been in this hospital before and they've had a group and save, then you're probably going to need to do one. You want to check that INR. You want to do a full clotting screen, because they might bleed in theatre. And seen as they're unwell, you're seeing them acutely, you're going to want to do a VVG. There you've got your hemoglobin, your potassium, and your lactate straight away. And then there's other investigations that you would consider in certain circumstances. If they've got existing lung disease and they've got low SATs, you might consider doing an ABG. If you think they've also got an infection, you might add a CRP. If you think they've also had a heart attack, you're going to add a tropon. If you think there is a pathological fracture, you might add LFTs and a bone profile on. And if you think there's an infection, we treat it. You're doing a full infection screen, blood culture, sputum, urine, wound swabs. And if they've hit their head, a CT head. So not everyone that's hit their head is going to get a CT head. But if, for example, if they're on a blood thinner, if they're on a DOAC, you're going to get a CT head. If they've had anything that would make you think they're changing GCS, increased confusion, or they've got a big injury on the head, then you're going to get a CT. And all that can happen in ED. So what the consultant is going to ask you is, can you get them into theatre in the next 24 hours? So the thing that you need to do when you're clerking is make sure everything that can be corrected acutely is corrected. So you need to check that their sodium and their potassium are okay, check their hemoglobin. And every hospital is going to have a different policy. But if their hemoglobin is low, for example, less than 90, give them a unit. If it's more than 90 but less than 100, then you just want to cross-match them for theatre. They're going to be in a lot of pain. They've fractured their hip. Do they need a femoral nerve block? When they get their pain under control, they're going to be in a better stage for going to theatre. And if you don't believe that they're fit for theatre because of deranged bloods, they've got a raging infection, things like that, it's really good to get advice from the med reg, because they're going to be able to deal with the medical problems, even though it's a surgical patient. And all these things need to be corrected before the consultant comes in the next day and decides that they're going to do surgery on them. So when do you need help? It's sometimes difficult to think with a hip fracture, what is just a hip fracture, and when do I actually need to alert this to my senior straight away? If a young person comes in with a hip fracture, you're obviously going to tell TNO right away. If you think that their nerves are compromised or their vascular supply is compromised, you're going to need to alert your senior straight away and probably go straight to vascular. And if you can't medically manage them, if they've had a massive P, if they're septic, then you're going to speak to the med reg on call to stabilize them first. So the patients all need to be stabilized before they go to theatre. So also when you're clerking, you're going to think, what do I need to prescribe? So you're trying to manage everything to get them ready. So they need pain relief. Think about paracetamol, Oromorph. If you want to give lower dose on Oromorph, particularly if these patients are elderly. And you would use oxycodone for patients with a low EGFR. And remember to reduce doses with people with low body weight. Also, because they've got a bone injury, you would avoid NSAIDs. These patients might be sick, or they might be sickness might be caused by their pain, or for example, all the Oromorph that you're giving them. So you want to give an antiemetic like ondansetron, and you're giving lots of pain relief to these patients. They're also going to get constipated, so they need laxatives. And they're elderly, they're in hospital. The last thing you want to get them is constipated. You need to optimize their nutrition. So the policy at our hospital is pre-op, get 2 bottles of Fortisip at 6 p.m. before the surgery and 6 a.m. morning of the surgery, and then Fortisip's BD post-op. You also will want to give IV fluids. For example, give our hospital loves using Hartmann's, but I know some hospitals prefer to use saline. And particularly if they've got something like a high lactate, they're dehydrated, they've got an AKI. And really important, as I said before, if someone is on long-term steroids, then they're going to be suppressed. So you're going to need to give IV hydrocortisone. That'd be something important to discuss with anesthetics to make sure they're aware. VT prophylaxis is very important in TNO surgery. So you need to complete their VT assessment. I imagine most hospitals have a VT assessment in their Clerking pro forma. And then if they're a risk,